Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon, everyone, and welcome to our 4th annual VITALS series. We are kicking it off this September with an incredible speaker today. First, as all of you know, VITALS is meant to be an open forum for engagement and discussion about our biggest problems in healthcare. We bring in national leaders who will come in and talk about how they use the tools of VITALS: value, innovation, technology, advocacy, leadership, and service to improve healthcare for our patients and our communities. We are very fortunate today to be joined by Dr. Daniel Simon. Dr. Simon is a friend and a colleague. Many of you may know him. He is currently the President of Academic and External Affairs and Chief Scientific Officer for University Hospital Systems. He's also a Professor of Medicine and Senior Associate Dean for Academic Affairs at Case Western Reserve University. Dr. Simon is the consummate medical leader. He is a great researcher, an innovator, an educator, and a clinician. He has not only done it all, he has done it all incredibly well. He currently leads University Hospital's research enterprise, over $180 million annually, with 3,000 plus ongoing clinical trials within the system. He also oversees University Hospital's graduate medical education programming and their affiliation and academic partnerships with Case Western Reserve University, Northeast Ohio Medical University, Oxford University, Technion, and also the National Taiwan University College of Medicine. He's still a practicing cardiologist, very heavily involved in clinical trials and research. He's received numerous research awards and was elected to the American Society of Clinical Investigation, the Association of University Cardiologists, the Association of American Physicians, and he's a recipient of the prestigious Merit Award from the National Heart, Lung, and Blood Institute and the 2016 Distinguished Scientist Award from the American College of Cardiology. He is also a fellow of the American College of Cardiology. He graduated summa cum laude from Harvard College, went on to complete medical school at Harvard Medical School, trained in internal medicine and in cardiology at Brigham and Women's, and completed a fellowship in interventional cardiology at Beth Israel Deaconess. There's so many more things I can say about Dr. Simon that would take really pages and pages. I don't normally use notes, but I did today because I wanted to make sure I hit the highlights. But I do want to note that Dr. Simon is also an innovator and an entrepreneur. He is the co-founder of Sujana Biotech and Kaleida Therapeutics, startup biotechnology companies developing novel monoclonal antibodies for a range of inflammatory and vascular disorders. We're really excited to have him join us today and share the impact that he is having using the VITALS tools to improve healthcare. Dr. Simon, without further ado.
Well, it's truly an honor and a privilege to be here today. It's a little embarrassing to hear those words, and we always like to say, I wish my mother was here, but she is watching on Zoom today, so I'm glad you said that. Well, it's really, it's so nice to be amongst friends. Our relationship with Neomed is growing. And I want to speak to you today very briefly in 17 minutes about harnessing research to address unmet need. Now, this is the single most important slide that I want to share with you, and especially with the students. Why is research important? Research is important because it's really all about hope. It enhances health system differentiation, but most importantly, it offers hope for patients who have no options. It creates competitive advantage for health systems by attracting patients seeking cutting-edge care, new drugs, new devices, new cell-based therapies. These are very important for patients with difficult medical problems, but they're also important margin generators for health systems that need that to fund research. Research improves healthcare outcomes by implementing evidence-based practices, and most importantly, it is the basis of our attraction of healthcare leaders, physician scientists, researchers, innovators, industry partners, and trainees. It produces important intellectual property. It drives philanthropy, and importantly for communities, every dollar invested in research creates $2.6 of return on investment. It has enormous biomedical system, ecosystem impact. I'm not able to advance. Now, just some key ideas about how can you organize research. And I want to give a few very simple lessons. The first, you need a strong mission statement. To heal, to teach, and discover is ours. Obviously, this is about discovery. But it's this vision of advancing the science of health and the art of compassion that is so important. We are driven every day by the notion that we want to be a next generation academic health system dedicated to accelerating discovery, innovation, and translation of scientific breakthroughs which address unmet clinical needs and enhance the lives of our patients, our community, and the world. This is not research for grant attainment only. It's not research for publications. It's research to make a difference for our patients. Now, a lot of dollars are involved in research. I include a little bit here. We are continuing to grow, and our total research portfolio will be closer to $200 million in 2023. A lot of faculty are engaged, over 1,100, 3,400 plus clinical trials now, 1,200 residents and fellow trainees producing a lot of good work, over 1,200 peer-reviewed publications with over 1,800 medical students, M3s and M4s, rotating through our health system. Now, why is research also important? It elevates your health system. In the only global ranking by UK Brand Finance of clinical research and education, UH soars through these rankings to be ranked 25th in the globe, 11th in the US. So research is very important for bringing profile to your health system and for attracting physicians. Now, what's a must-have? Lesson number 2, do research that impacts clinical activities. The second one is you have to be really focused. And this is a call out. You must have a strategic plan. And I call out the great Tom Enders and Alex Morin from Enact Health. We have engaged with them now 4 times in our health system to drive a strategic plan, to focus, to measure, and come back and renew. And this is very important for those who are listening and those who are here. You must be guided by a clear strategic plan. Strategic partnerships are key, and President Langell talked about them. They're citywide, they're statewide, and they're global. And you'll hear momentarily about how these partnerships are so important. Research is a team game, and you need great partners to be able to succeed. Alignment between health systems and medical schools are critical. We have a joint strategic leadership committee that mines this relationship between UH and Case Western. We have a joint strategic operating group that manages that relationship between UH and Neomed. Having senior leaders at both finance levels, operational levels, and research levels is very important, because ultimately, what is it all about? Alignment for recruitment. It's all about the people. And you can see here in this wonderful, wonderful slide of amazing recruits, joint recruits and retentions of very phenomenal researchers who are helping us advance our mission. It's also important to point out that the full spectrum of research is required. You cannot focus only on basic scientific discovery. You must translate that. You must do clinical research. And then very importantly, we impact our community and the world through health services research and health implementation science. And in a few minutes, I just want to go around this wheel and show you great examples of how this really affects patients. Of course, one thing that's really important that I talked to you about is in this strategic plan, focus, focus, focus is very, very important. You cannot be great at everything. And our focus areas include brain health, cancer and immunity, imaging, rare disease in a partnership with Oxford, and cardiometabolic disease. Of course, we will fund activities outside of this, but the bulk of our investments are in these areas of focus. And it's very important to point out, it's great to be aligned with your medical schools in these same centers of excellence areas. The third lesson, the importance of building research teams. Science is no longer the single funded R01 scientist. It's all about bringing teams. And you can see here, tremendous teams that have come together. Peter Pronovost and Marley Miller for health services research with PCORI. Our very own Grace McComsey, the PI of the CTSA-CTSC that Neomed is now on, a $62 million grant focused on clinical research. A second grant related to pathways of injuries in Barrett's carcinogenesis, $13.5 million, and a vision center and a core grant for $3 million. These are taking investigators together, dozens of investigators under the principle that a team can accomplish more than an individual. Now let's just take a peek quickly at basic and translational research. I want to give you a great example of work that Jordan Winter has done, a surgical oncologist studying pancreatic cancer, who identified a very specific target, IDH1, in pancreatic cancer. This is a cancer that has a 5% 5-year survival rate. But what's important about Jordan's research is he did not stop at identifying this target. You can see right on the right of this slide, he goes along to start a clinical trial, partnering with the Gateway Foundation and donors to try this new therapy based on his target in 12 patients, going from bench to bedside within 12 months. Truly a phenomenal observation that he's been able to make and then translate that right to the bedside. Now, also want to show you again this concept of team, the importance of teams. This is our MRI Research Center of Excellence. MRI fingerprinting, a way to use MRI to virtually do virtual histology of tissues being applied from brain tumors to breast cancer now, prostate and pancreatic. This group has come together, tremendous partnership with Siemens and the National Institutes of Health to have over $42 million in funding related to cancer imaging, diagnosis, prognosis, and follow-up. And those are the kinds of examples that we strive to support as a health system. Now, one of the things that I've talked about is this gap between basic discoveries and actually bringing them to the bedside. And how do we do that? I want to share with you a very intentional effort that has really separated our health system from many others related to breakthrough discoveries into new medicines, creating new drugs. And that's the Harrington Project for Drug Discovery and Development. It combines very important nonprofit models with for-profit investment partnerships to commercialize new drugs. It's virtually unique when it was developed over 11 years ago, because 11 years ago, it was very unusual for nonprofit health systems and even medical schools to have venture funds. And now everyone has a venture fund, but it's hard to do. And I want to share just a little bit of that with you. We have 4 centers of focus in the Harrington Discovery Institute: a major disease center for cancer, cardiovascular, and neuroscience, a brain health medicines group, a group that was focused just on COVID-19, and a rare disease effort predominantly with Oxford in the UK. Now, what is the principle of this? The principle is failures in drug discovery. You need many, many, many shots on goal to get a drug into phase 1 clinical trial. Over 90% don't make it to phase 1 trial. And then as you go through phase 1 to phase 3, further failure rates as high as 80 to 90%. We source projects, the best drug targets from around the country in the Harrington Discovery Institute. Our secret sauce is this therapeutic development center that helps milestone-based investigators to take these discoveries into things that actually can be brought into the clinic. We invest in them, we de-risk them, and then we pass them off by licensing agreements in pharma to accelerate discovery. Well, how have we done? In the past 10 years, we have funded 177 new drug investigators from 64 institutions in the country. We've launched 36 companies. We have 19 medicines in the clinic and 13 licenses to pharma. In my own case, Kaleida Therapeutics, a NewCo that spun out as a consequence of research funded in my laboratory related to inflammation, is now humanizing a monoclonal antibody, the ones like you see on TV, Ocrevus, Humira, and others, to bring to patients for a variety of indications. This is a long, expensive road, but academic medical health systems have to be involved in accelerating the generation of new medicines. Well, what about clinical research? Of course, this is what many of you think about when you think about helping patients. And I want to share with you an amazing example of our very own Dr. Mehdi Shishabur, and Monica Robbins from WKYC is smiling because he's done stories on this story right here, which is that in the United States, we have over 50,000 amputations per year. Once you have an amputation, typically as a consequence of diabetes, your 2-year mortality approaches 50%. Dr. Shishabur is one of the most skillful physicians in being able to reestablish blood flow and prevent amputation in a technology called LymphFlow that was approved by the FDA 2 days ago. And as you can see, garnered Dr. Shishabur a first author paper in the New England Journal of Medicine reporting on the success of this incredible technology. Now, research is all about the people. And we have an incredible Pied Piper in Dr. Dan Spratt, the youngest professor ever at the University of Michigan, a radiation oncologist who he recruited. He was a former MMA fighter and bodybuilder who went into medicine because he was a physical therapist. And one of his patients who was a doctor said, you know, you should think about going to medical school. And Dr. Spratt has just lit a fire in radiation oncology. You can see all of the people that he's recruited here. Grant funding is soaring. And Dr. Spratt just published a very important paper about using AI in the treatment of prostate cancer to decrease complications in prostate cancer. This is the wonderful research that you can have when you recruit great leaders and you support them to bring amazing individuals along. Now, finally, we really want to impact the community. We want to impact the patients. We want to impact their families. How do you do that? There's a tremendous gap in getting approved technologies, vaccines as an example, which have been approved, but to get people to actually use them. That type of research is called health services research or health implementation science. Dr. Eli Sadi received a $12.5 million grant that was just $18 million to study why is there limited use of vaccines in very important communities. And you can see here, the Corvitz grant is looking at social determinants of health to look at vaccine effectiveness in areas of health disparities and inequities, mostly in underrepresented populations. This is a consortium of researchers who are coming together saying, we have these vaccines. RSV vaccine took 55 years to develop. It is now approved by the FDA. How many seniors over 60 How many pregnant women in the third trimester are going to get this vaccine? And if not, why not? That is health services research. Now, to conclude, I want to stress the importance of the fact research is a team sport. There are a lot of people behind this effort. And when you build these research efforts, it's important to be sure that this is adequately supported. This is the team that runs the UH Research and Education Institute, that manages this $200 million research portfolio, that manages our 1,200 residents and fellows and our 1,800 medical students. They do a great job, and I thank all of them for their hard work every day. The other thing that I want to point out, though, is that we have to also think about pursuing new sources of research funding. Of course, we rely on the National Institutes of Health, the Department of Defense, the National Science Foundation, PCORI, HRSA, and ARC. But we have this wonderful, wonderful team of foundation and state and other federal grant writers that come together to support our researchers. They look for RFPs. They help them write their grants. They come together to support them. And in 2022 alone, this small but mighty group was responsible for $35 million in grant attainment. And this year, it looks like it's going to come in over $45 million. So thanks to them as well. Of course, you have this amazing social media engine here today. We're on Zoom, we're on Facebook. We have several hundred of you here live today. But if you don't get it out, people don't know about you. So social media, your marketing teams are critical. And of course, we have a great one behind us, as you do here as well. Now, the final lesson, I think maybe lesson number 5, is this issue that the academic mission requires enormous investment. And for the leaders who are listening, I want you to know that if you look at the AAMC, no matter how good you are in research, the average investment per dollar of research that you receive is another 56 cents in addition to the indirects that you receive. And you can see here that while UH has been growing its research portfolio to $200 million a year, the investment of the health system has come along with it, investing over now $200 million in 2022. So what are the key take-home messages for today? Academic medical centers should be dedicated to accelerating discovery, innovation, and translation of scientific breakthroughs to address unmet clinical needs that will enhance the lives of our patients, our community, and the world. Grant attainment, publications, and H-index is not enough. You have to go from bench to the bedside. And when you're at the bedside, you have to make sure that these incredible discoveries are getting into your patients. You need focused commitment, strategic planning, metrics, and centers of excellence. You need recruitment of diverse faculty to promote team science through collaborative and interdisciplinary efforts. And the other thing to understand is that research will help you augment revenue streams for your academic activities. Federal foundation industry grant support will lead to intellectual property and commercialization that ultimately has promise for incredible royalty and equity streams. And of course, grateful patients make incredible donors, and they love giving to research. So it's an important driver of philanthropy as well. So the take-home message is, it takes a team to make research happen. Thank you. And now I would like to introduce Monica Robbins, a good friend over the past 15 years, who is the senior health correspondent for WKYC. Monica.
Great to see you, Dr. Simon, and welcome to all of you. I think this might be the biggest ad in quite some time. And we also have 62 folks on Zoom. So welcome to all of you as well. There's a Q&A section for the folks on Zoom. If you have any questions, feel free to put them in. For our live audience, there are microphones on either side. Feel free to step up to the microphone and ask Dr. Simon a question. We already have one coming in on Zoom. what advancements can be made in clinical treatment and research to deal with large-scale trauma and the impact on mental health that results from the increase in natural disasters occurring globally?
Yeah, Monica, that is really that's a terrific question. And in fact, really, I perhaps should punt to Dr. Langell and Dr. Basson, who are actually trauma surgeons. But I would say there is no question, as a cardiologist, we have a robust literature that if you look, for instance, at the earthquake in California that took place many years ago, and if you looked at sudden cardiac death and heart attack before and after the earthquake, there's an enormous spike in heart attack, showing that stress and anxiety and response to the disaster has a big impact on health outcomes. We know that that's the case in other disasters that happen, floods and hurricanes as well. I think what I would say is I do know that the National Institutes of Health is very focused on this. The train derailment disaster that happened in East Palestine has led, for instance, to a number of research teams, many of them centered at Case Western, looking at not only the health impacts from a cancer standpoint, but behavioral health impacts on both adults and children. So I think that these oftentimes are the direct result of very quick requests for proposals from federal agencies to seek applications for that. And I think that obviously there are groups coming together worldwide to do that. But perhaps Dr. Langell or Dr. Basson could comment later.
Okay. You made a great point. Research takes money. We all know that. And with the NIH, I understand that maybe one or two submissions actually gets funded each year. And you had mentioned 90% fail in general. So for many of our medical students here who may be interested in going into research, just preliminary research, getting it into the lab takes money. And for a younger researcher, that's nearly impossible. So as these folks go out and look for careers potentially in research, what's your advice to them?
Well, I would say, Monica, that being a researcher is a little bit like being like a baseball player. In Major League Baseball, you make the Hall of Fame if you hit 300, so 3 out of 10 times. You are correct. When you apply for a grant right now, funding rates can be as low as 10 to 12%. There are early stage investigator exemptions and training grants that fund a little bit higher into the mid-20s now. So that means that what do you have to do? You have to be resilient. And as we say to our students and to our young faculty and our postgraduate researchers, is you need a lot of shots on goal. If the success rate is only 20%, you got to have 5 grants. So you're going to get 1. And so that's hard because it's a lot of work. A grant submission is enormous effort. But I would say the following: both university hospitals, Case Western, NeoMed, and many others here have tremendous mentors who are successful research faculty who take students in and support them. We have training grants that are designed to support students to get into the research realm and then to become funded. My career was launched by the American Heart Association Massachusetts affiliate. I applied for a beginning fellows grant just out of my residency and was very lucky to get funding. I think we're all very fortunate that we have great mentors who help guide us to become successful. And then even when we're faculty, senior faculty help. So it is a tough road, but I have to say that when I think of all the things that I do in my career, administration is the hardest. It's also the least fun. The thing that's really fun is going to see patients in clinic and making a research discovery. There is nothing that comes close to having a truly unique research discovery that identifies a new target in all of biology. And it is very, very hard because to be a great basic scientist, if you publish 1 to 2 high impact papers a year, you are doing a phenomenal job. And it's very hard, but I think it's very rewarding. And as I look out to all these young faces here, I would say there's nothing like research, and you have great opportunities from both basic research to translational research to clinical research to health services and implementation science to make a difference around that wheel that I shared with you.
I'm glad you brought up LimFlow with Dr. Shishabor, because I covered that device for almost the 10 years that he was researching it. And I get asked all the time, from the first time I saw it with the first patient,
Yes.
it just seemed like common sense
Yeah.
to me. So why is it so difficult to go from basic discoveries to new medicines or devices?
Yeah, it's a great question. Let me take devices first. So device path is actually much faster than drugs. If you look at the timeline from target identification to clinical trial and approval, could easily be 2 decades. Devices can be much faster. And when I mean much faster, I would say 5 to 10 years. But that's still slow. And I remember, like it was yesterday, traveling to Portugal to do the first transcatheter valve replacement procedures for aortic stenosis. This device was developed in France, approved in Europe 5 years ahead of the United States. And a group of us traveled to Portugal to do cases to learn about this technology, because the approval path for devices is so much faster in Europe than it is in the US. The US has an overarching protection of safety over efficacy. And in Europe, there's a greater balance between efficacy and safety, and a desire to learn more about safety in the post-approval period. So the trials are smaller and faster, and they're more nimble. So there are trade-offs. There are trade-offs with that. What I would say with LimFlow is you're absolutely right. If the artery is blocked, why not turn the vein into an artery and reverse the blood flow? There are 3 main veins that go to the leg. Turn one of them into an artery and let the other 2 veins function on the return. It sounds simple. It starts in animal models, from smaller animals to larger animals, and then eventually makes it into patients. But it goes through what we call that phase 1, 2, 3 progression. Phase 1 really for safety, phase 2 for trying to understand what's the right population around safety and efficacy, and then phase 3, the definitive clinical trial. There have been a lot of device failures, Monica, and I've been involved in a lot of them. LV parachute for aneurysms and heart failure. The list goes on and on. We think they're going to work, and when they get into clinical trial, there's no benefit. We can't expose patients to devices that aren't going to be beneficial in the long run without doing clinical trials. We need clinical trials. We think they're going to work, but we're not 100% sure. And what we call that in clinical trial speak is there's equipoise. The chance of success and the chance of failure has to be in balance. That's how institutional review boards, IRBs, allow you to consent patients. We have beneficence in mind, but we're not sure, and we don't want to cause harm.
COVID sort of threw all that out the window, though. So what does it take to accelerate the implementation of research solutions as quickly as we did with COVID?
Yeah, I think you're raising a tremendous issue here. If you think about the fact that we identified the virus in December of 2019, January of 2020, identified it as being a coronavirus. We had crystal structure from many others. The sequence was placed, and then, of course, an Oxford research lab generates the first vaccine and licenses to AstraZeneca, and that's out in under 6 months. That is an incredible commitment and global effort to say, this is a pandemic. The safety of the world is at stake, and resources were dedicated to it. I think that should be the model for how we can be more nimble in research. Fortunately and unfortunately, the solutions for coronavirus and for COVID were relatively straightforward because of our experience with the other coronaviruses. It's not been so straightforward when you look at RSV. RSV is the #1 cause of death of newborns up to 6 months of age from respiratory illness. We have been trying to get a vaccine for RSV for 55 years. It also is responsible for about half the number of hospitalizations and deaths that flu is in the elderly. It took us 55 years. The science would not give way. I was an intern and a resident during the very start of the HIV/AIDS era, when we didn't even know what the cause of HIV/AIDS was. We still do not have a vaccine today. Some diseases are outsmarting us, and we just don't have the knowledge yet. I'm hopeful that we'll have a vaccine for HIV/AIDS, but RSV took 55 years. I'm embarrassed to say, I guess, that I was a resident back in 1985 and 6 and 7. So, as a student and then a resident in 87. So I'm pretty old. They've been going at this a long time, and we still don't have a vaccine for HIV.
You talked about resources being thrown at things, and we saw that, trying to explain to folks about mRNA vaccines, that technology had been around for 20 years.
Right.
They just couldn't get it out of the lab into patients.
Right.
The big thing that changed that, focus and a lot of federal dollars. Is there anything on the horizon right now that you're looking at that you think in your mind would warrant something, that targeted attack to getting a therapy out there?
Yeah, well, I think if you look at the biggest opportunities worldwide, globally, we still have tuberculosis that kills millions and millions of patients a year. No real good cure for that, no vaccine. Malaria, millions and millions of patients now has a mildly effective vaccine. Excuse me. Of course, we're very concerned about cancer, and the improvements in cancer survival have been very, very impressive. However, we have a long way to go. And if you look at the cancers that are responsible for large numbers of deaths in the US, lung cancer, for instance, it has lagged behind. Some of the therapies have lagged behind benefits in immunotherapy that other areas have benefited from. So I guess it's hard for me to say. I think that the diseases that potentially have the biggest bang for the buck globally, as an example, would be cardiovascular disease. There have been wonderful, wonderful trials now with something called the poly pill. It's a pill that Valentine Fuster and Salim Youssef from Canada have worked separately on to say, can I give a patient a simple pill, all generic medications, pennies a month to treat, that combine a blood pressure pill, an antiplatelet agent like aspirin, with a statin medication and a single blood pressure medicine, 4 pills potentially in total, reduces heart attack, stroke, death by over 30–40%. Yet we don't use them globally in polypills. And why is that? It's very complicated. It's got a great story behind the power of pharma. Is this a therapy that pharma in generic really wants to support in the developed world? Perhaps it would support it in the developing world. And it's not surprising that the polypill trials were done, for instance, in the developing world, in India and other places in Asia. So this is a very complicated subject. It can get a little bit controversial. I think we have more solutions than we're implementing. And, the one thing that I would say to speak to the importance of health services and health implementation science is my own field of cardiology. We know that heart failure is the #1 cause of hospitalization in the US and the #1 cause of readmission for hospitalization. It costs over $30 billion a year. We have 4 classes of drugs that reduce hospitalization and death. And if you look at guideline-directed medical therapy and how it's implemented in the US, less than 25% of patients are on guideline-directed medical therapy, which means we have these approved drugs. We've done these expensive trials, and the patients and the doctors aren't using them correctly. Why? That's something that we need to overcome. If you look at high blood pressure in the United States, only 25% of people with high blood pressure are less than 130/80. We know programs that can take that up to 69 to 70%, but we haven't implemented them uniformly. So there are a lot of challenges in healthcare, and what gives me the greatest optimism is all these young people here.
Absolutely. But they're very shy. So
Yeah.
I'm wondering why no one is up at one of these microphones yet. And our Zoom audience, please send us your questions. Oh, we have somebody.
Yeah, so you had mentioned social determinants of health a little bit. I'm talking about like vaccine uptake. And I just wanted to get your thoughts, I guess, on like the responsibility of innovators and of developers of drugs and so forth to make sure that the most vulnerable populations that need those drugs the most are actually able to afford and access them. And what UH and the projects you're working on are doing to make sure that happens.
Sure. So for those of you online, if you didn't hear well, the question was related to social determinants of health, health disparities and inequities, and the responsibilities of health systems. So this is a great question, and I thank you for it. So just some statistics to throw out. Ohio is 47th in the country in health disparities and inequities. Cleveland in Northeast Ohio is the second worst city in the country for health disparities and inequities, behind Detroit. So despite the fact that we view Cleveland as a biomedical mecca with two great health systems, medical schools in Northeast Ohio, Case Western and NeoMed, we have a 23-year life expectancy gap between Huff and Lyndhurst that are only 8 miles away. 23 years. And that life expectancy gap exists also in where I came from in Boston. So you think of Boston as a biomedical mecca. If you're in Roxbury compared to Back Bay, there's a 20-year life expectancy gap. So that raises that issue of what causes health disparities and inequities. And those are the social determinants of health. 20% of health is what we do as doctors, what you're training to do as medical students, what you do clinically in the hospital, in the ambulatory clinic, in telehealth. 80% is everything else: poverty, housing instability and insecurity, food insecurity, pollution, and the list goes on. Walkability, green space, temperature. And what I would say is that this is the challenge that we're facing now in healthcare. How can we tolerate these disparities and inequities? I'll give you something that we're trying to do in the health system. We've been focusing on our community, opening ambulatory health centers in Fairfax, Huff, and Glenville to tackle this problem, to improve access, and to address food insecurity through Food for Life markets sponsored with the Cleveland Food Bank, where patients with food insecurity can be referred by their doctor, and a family of 4 can be fed up to 6 months on one prescription. That will allow our patients to not have to make the very difficult choice between, do I pay the rent and feed the family, or do I buy medicines? And of course, buying medicines is going to be the last choice when a family is involved. This is very complicated. Our very own Sanjay Rajagopalan, who's a leader, considered probably the world's expert in cardiovascular disease and air pollution. There's 7 million excess deaths in the world from heart disease due to air pollution. And that's that 2.5 micron particle problem that leads to activation of our NF-kappa B system in our lungs, which then promotes atherosclerosis, leading to hardening of the arteries, heart attack, and to stroke. Sanjay is working with investigators from Wayne State in Detroit in an $18.5 million grant that's through the Cuyahoga Metropolitan Housing Authority, the Cleveland Metropolitan School District, and the health systems to use community health workers to go into the Cleveland Metropolitan Housing Authority to have interventions in cardiovascular disease, mostly focused on high blood pressure and diabetes. This is what it's going to take. And I think that it's a wonderful question. I think that students today and doctors who are in training have to focus on this. Climate change is very important in impacting disease. It's not just cancer. It causes lots of other diseases. And I think that we're trying. We have a long way to go, but I'm hopeful for the future.
And you brought up the complexities of this issue go far beyond, because there's not enough diversity in research. There is not enough diversity in minorities who are doing research. So in your Pollyanna perfect world, any solutions, any ideas? And what is UH doing now? Your surrounding neighborhoods are among the 23-year gap.
Right.
So you've already put a women and children's hospital in Huff.
Right.
So what are you doing to attract those individuals into a medical field that already has severe shortages, severe nursing shortages?
Right. I think it's a great question, and it couldn't be more pertinent for being at Neomed today. This is the basis of our strengthening relationship with Neomed. Neomed has been dedicated and focused on enhancing underrepresented minority students within the school up to, I believe now, I'll look out into the audience, about 27%. We believe, and there's very good data that racial concordance is critical for highest quality of medicine as well as patient experience. When you are cared for by a provider that's concordant to your background, your health outcomes are improved and your experience is improved. Cleveland, as you know, its city itself is 50% African American, Cuyahoga County, 24%. We are working to enhance that pipeline, not only from Neomed, but also from Case Western. Case Western recruits medical students from across the US. Many of those students come and do their residencies and then practice outside. What's great about a state-based medical school is the loyalty to that state and to that region, and the graduates from Neomed who disproportionately go into primary care, family medicine, internal medicine, pediatrics, and OB have a much higher rate of practicing here. And we think that that pipeline and the relationship that we have with Neomed is critical to develop the primary care, Monica, that you're exactly talking about, which is underrepresented minority primary care, focusing on disparities and inequities within our community.
All right, we have a couple of questions off of our Zoom. The basic and clinical sciences training model, while relatively young, has been in place for about 100 years. How does medical education need to change?
Yeah, that's a terrific question. So I'm thinking about this because my office is in the Lakeside Medical Center at UH, which is going to have its 100th anniversary in 2025. And that medical school relationship between the hospital being next to the medical school was a consequence of the Flexner report, which is about 100 years, which said doctors have to stop being apprentices like barbers. They need to be scientific. They need to be in a discipline. They need to be next to a medical school. So fast forward 100 years, my office is still in the same place. It hasn't really changed. So I think what you're driving at here is that medical school education is changing dramatically. When I went to medical school, as John and I were talking about just this morning, we had lectures in the morning. We had small case study in the afternoon. That's been completely blown up. It's all case study. It's all disease-based, and it's small groups, and it's much more interactive. And most importantly, it's interprofessional. So when I went to medical school, although I had dental students with me for the first 2 years, I never trained with nurses and social workers and pharmacy, even though now when we have medical teams, we all work together. We have advanced practice providers, nurse practitioners, PAs, pharmacists, social workers, all on our team. And medical education has changed because we now learn together. So I think that medical school today is better than when I went to medical school. Although John and I were laughing that I think it would be hard for us to be students today.
You brought up teamwork, and we see that on a daily basis. You also brought up teamwork relating to research. Another question from our Zoom: with wearables and other technologies, many patients have a heightened awareness of their health. Can health innovation occur at the patient level? And if so, should there be more encouragement of it?
Yeah, that's a terrific question. Thank you for that. Look, I would say as a cardiologist, one of the most transformative events in the last 5 years has been the Apple Watch detection of atrial fibrillation. So if you think about atrial fibrillation, it has on average about a 5% per year risk of stroke. And those strokes are large because the clots in the left atrial appendage are big. They cause devastating strokes that impact quality of life. We know that anticoagulation reduces that risk of stroke by 90%, but we have to know that the patient has atrial fibrillation. A lot of patients will call you up and say, Dan, I'm having palpitations. I'm a little short of breath. I feel mostly okay. I probably can wait to come to see you. And that's when the light bulb is going off, because once you hit the 8th decade of life, 10 to 15% of patients have atrial fibrillation. Think about it now. I have patients who call me up who say they have high blood pressure. They're at risk for atrial fibrillation. And they say, my Apple Watch detected atrial fibrillation. I think I need to see you. That is a huge change. That's empowering to the patient. And it puts that technology in their hand to not only monitor that, but also, for instance, to monitor, for instance, their exercise performance. We have a new wearable coming out of the Harrington project from Jonathan Stamler, which measures nitric oxide in the blood. We know that nitric oxide regulates blood flow in the brain. And the single most important thing to prevent cognitive decline in dementia is increasing blood flow to the brain. We now have a wearable developed by Jonathan through Knox that soon you will have access to, or in the third prototype, that will allow you, when you exercise, to monitor the type of exercise that you're doing and the amount of nitric oxide that you're producing. And in fact, when you're on the elliptical, which they've tested, when you add upper extremity to the lower extremity exercise, there is a burst of nitric oxide formation and enhanced blood flow to the brain. That's all available now on a wearable. So instead of us thinking, people call me up and say, Dan, I'm exercising. What's a measure of good exercise performance? And what do I say? Your target heart rate, 220 minus your age, times 0.6 to 0.8 in that cardiovascular zone, and your peak zone at 85%. That is so crude. That's the same target we used when John and I were in medical school. So this is going to advance. You're going to have the target of nitric oxide production. And am I enhancing, and am I getting to the target level of my NO? Because that's increasing not only my brain blood flow, but my skeletal muscle blood flow and blood flow in my heart. So it's coming.
Tell Jonathan I'll test that one. So
we'll get one for you, Monica.
During the presentation, you mentioned the use of AI in the medical field. Currently, the sophistication of AI is like the internet in 1992. What does the future being with harmonizing medical with AI and teaching students how to utilize AI effectively?
Yeah, so this is really critical. I'm glad you asked it to talk about it, because there are a lot of concerns and misconceptions about AI. There's some feeling that you're going to replace me and other doctors. You'll walk into an office and you'll be talking into a computer, and ChatGPT will tell you what your diagnosis and your therapy is. That's way off in the future. What I would say now is to give you one example of how it's really helping us is work that we've done in fracture detection with a company called AZMed that just received FDA clearance for fracture detection. So those of you who are interested in becoming radiologists and working in emergency rooms, think about this challenge. In our emergency room at any given time, not only do we have about 50 or 60 beds, but we have 40 people in stretchers in the hallway of those beds. So imagine 100 people in there, and x-rays are piling up for that radiologist. And there are x-rays there saying, rule out fracture, rule out fracture. We now developed a fracture detection AI-based system with AZMed that's been approved, in which this AI-based system is faster than a doctor and also about 11 to 15% more accurate. Now, it doesn't mean that the patient is coming and leaving the hospital without the radiologist seeing the x-ray. But what it does mean is that x-ray is previewed and rises to the top of the queue to say, this patient has a fracture by our fracture detection algorithm. It's the same way that we've used an AI-based solution to detect pneumothorax. So whenever we put a central line in place, we're worried about a puncture of the lung and a pneumothorax, and everybody gets a chest x-ray. Well, now there's an automatic detection for a pneumothorax. That X-ray is done, the radiologist is notified, and the team is notified right away. So that's the type of AI, I think, that is in place now. It's been approved by the FDA. It goes into the areas of digital pathology and many others. I talked about Dan Spratt, who developed an AI-based algorithm that shows that 40% of men who are put on therapy to stop testosterone production, basically medical castration for prostate cancer, it's unnecessary. So we're now identifying that 40% of those patients who are getting all the complications of no testosterone, fractures, lipid abnormalities, behavioral health issues, hot flashes, 40% is unnecessary. And that came out of an AI algorithm looking at hundreds of thousands of patients with prostate cancer. I think the future for AI in medicine is very, very bright. But I think what we need to be careful about is don't worry, it's not going to replace your doctor, it's going to enhance your doctor.
Dr. Simon, you are a cardiologist and NIH-funded basic scientist who has for over 30 years in the research lab focusing on inflammation. Tell us about your journey and your new biotech company.
Well, I think, this is a long story, and I think shows you all of the ups and downs of basic discovery in research. You can spend many, many years identifying a target, knocking it out in the mouse, and as a lot of the researchers here know, curing disease in mice. And we've done a great job at curing multiple sclerosis, lupus, vasculitis, restenosis, and thrombosis in mice. But the real challenge now is bringing that into the patient. And for about the last 5 to 7 years, we've been focusing on how to take that target that we identified, a specific receptor on a white blood cell, a receptor called MAC1, CD11b, CD18. We've done mutational analysis and structural studies. We know the specific region in the molecule that's responsible. And now we're making a monoclonal antibody. We have that monoclonal antibody, but that monoclonal antibody is a mouse protein. And now we have to make it a human protein, just like your Humira and Stilazza and Ocrevus. And that takes time. I think that I will be lucky in my lifetime, and that's my hope. I'm holding out that I will see that antibody drip into a patient in a phase 1 clinical trial.
All right, final question, and I want to thank the live audience, but I can tell class is coming soon. And thank you to our Zoom viewers as well. Is there enough need to discover, heal, and teach in Northeast Ohio, or does UH need to expand its footprint?
Oh, that's a great question. Well, I will say something here. UH will only be in Northeast Ohio. Our Northeast Ohio is growing. When I came from Boston in 2006, we had about 8 hospitals and joint ventures. We now have over 21. We're in 16 counties. We were $1.5 billion health system. We're now $5.5 billion. We had about 15,000 employees. Now we have 33,000, but we're not going anywhere. We are the hometown team. We were founded here in 1866 based on the principle that the needy are the most worthy. We're staying in Northeast Ohio. We're not going to Florida. We're not going to Asia. We're not going to the Middle East. We're stuck here in Northeast Ohio, and we're just going to make things better here.
All right. Dr. Simon, thank you. We'll hand it back over to Dr. Landry.
Dan, that was an amazing talk. Thank you very much. And thank you to the audience for your participation today. Please join us next month. It'll be the first week of October when we will hear from Kendall Cobb, who's the Associate Chief of Staff for the Cleveland Clinic, to speak to us on the work they're doing in health equity. Until then, stay active and stay engaged, improving the lives of our patients.
This is VITALS, Visionary Health Leadership in Action.